have you got the mail?
Not yet, sir. Not yet, sir. I haven't.
To me, it has been delivered. So
Yes,
I
sir. Yes, it's
I require.
delivered. It's
Yeah,
delivered
yeah.
now. It's
Okay,
delivered
okay.
now.
Okay. Ms. Shweta, you can start. You can start.
Yes, sir.
Yeah.
So,
Go ahead.
good evening and welcome to one and all. I'm Shweta from Clarnet, the designated session assistant for a seamless experience of the session. Clarnet is very proud to be a digital partner for this event organized by Indian Society of Pediatric Neurosurgery. And the topic of today's session is biomechanics of pediatric craniovertebral junction and its applied aspect. Clarnet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Let's begin today's session, for which I would like to hand over this session to Dr. Suhas, sir. Over to you, sir.
Thank you, Shweta. So good evening, everybody. Welcome to this sixth virtual classroom for pediatric research residents. This is an industry and endeavor towards teaching our residents about the pediatric neurosurgical topics, both basics and advanced, through different faculties from our own country. So the topic for today is biomechanics and management principles of craniovertebral junction. The speakers or our teachers are two eminent faculty from Sanjay Gandhi Postgraduate Institute, Dr. Ved Prakash Maurya and Dr. Arun Kumar Srivastava. And we always involve a guest institute, and this time the guest institute is GB Pant Institute of Medical Sciences, so it's JIPMER. And the faculty involved is the director, head of the department, and Professor Dr. Anita Jagatia. So together, we'll start off with the biomechanics through Dr. Ved, and then we'll go on to the applied aspects by Dr. Arun, and Dr. Anita will take over the discussion and a presentation through her resident. So reminding all of you that this is an industry endeavor which would happen every month at the last Sunday between the 7 to 8 p.m. It's a regular class, so please try joining us regularly. Dr. Arun and Dr. Ved, you can take over.
Good evening, sir.
Yeah.
Thank you for the kind invitation.
Thank you.
Ms. Shweta, so I will be able to change the slides of my own, or you will be
No, sir, you have to tell me next.
Yeah.
Okay. A very good evening. First of all, I am very thankful to Indian Society of Pediatric Neurosurgery for providing me this opportunity for this lecture in virtual class, which is a INSPN endeavor for neurosurgery trainees and residents. So today I'm going to speak on biomechanics of pediatric craniovertebral junction. Next, please. So I will be covering my presentation in following headings like basic introduction, embryology, neuroanatomy of the structure, and biomechanics of normal and pathological anatomy. Next, please. So as we know that craniovertebral junction is not only transition of the cranium to the spine, it is actually the transition of cranium and spine, as well as neural structures like transition from brain to the spine. It carries craniovertebral junction, cervicomedullary junction, complex muscular structures and ligaments along with the vessels as well. So this mobility comes at the cost, that is at the cost of instability. Next, please. So management algorithm for craniovertebral junction anomalies can be understood by understanding the development of this structure, neuroanatomy over this complex area, and biomechanics. Biomechanics, which involves assessment of the functional anatomy via radiology in the form of CT, MRI, plain radiogram, X-ray, based dynamics. Motion studies is often critical to reveal the pathogenesis of craniovertebral junction lesions and their proper management. Next, please. The development of craniovertebral junction musculoskeletal structures covers the occiput and the cervical sclerotomes, which contribute in the formation of craniovertebral junction. As we know that the first two occipital sclerotomes forms the basic occiput, and third, fourth sclerotomes contribute in the formation of anterior tubercle of the clivus, anterior arch of the atlas, os terminal of the dens, the alar, cruciate, and apical ligaments as well. Fourth occipital ligament contribute in the formation of anterior margin of foramen magnum and occipital condyles. Next, please. Next, please. This is a slide. It looks like a puzzle, but if we see it, it gives the formation of the structures over the craniovertebral junction. As we said, that the occipital somites first, second, and third contribute in the formation of base occiput and basion, and fourth occipital somite contribute in the formation of proatlas. Then the cervical somites number 1, 2, and 3 contribute in the formation of cervical sclerotomes first and second, and these in turn lead to the formation of anterior arch of the atlas, posterior arch of the atlas, apex of the dens, and base of the dens, and body of the axis. So this dotted dark line shows differentiation of the cranial development and upper part of the cervical development. Next slide, please. This picture shows the ossification of the occipital bone in the form of synchondrosis, which separates the supraoccipital and the ex-occipital segments, which fuse between 4 to 6 years of age. This differentiation is important so that we should not get confused with the fractures in the pediatric age group. Next slide. Next is the atlas, which is composed of 3 primary ossification centers. Anterior arch, right and the left posterior neural arch are separated by synchondrosis. These fuse by the age of 8 years of age. Next slide. The form of for atlas, the 2 posterior neural arches, the vertebral body, right and left sides of the odontoid process. They are the ossification centers, and the neural arch fuse posteriorly by 2 to 3 years of age, with the body of the odontoid process between 3rd to 6 years of age. Ossification of the apical dens and fusion across the upper dental synchondrosis is not completed until adolescence. So in our daily practice, we should not get confused that there is fracture of the dens. Next slide. This slide shows the neuroanatomy of the craniovertebral junction. So superior view of the atlas and the inferior view of the atlas, we can see the articular surfaces of the atlas, which articulates with the occipital condyles, and the inferior surface have the articular surface for articulating with the superior facet of the axis. And then axis anterior view, we are seeing the dense body of the axis and the articular surfaces and the foramen transverse area. This is the posterior view, which shows the posterior articular facet for the transverse ligament of the atlas, which helps in aligning the structures. Okay, next slide. Interior view of the craniovertebral junction showing the ligaments, which are very important to hold the structures in place. That is the tectorial membrane, alar ligaments, and the most important is the transverse atlatenoid ligament. Superior extension is called as superior longitudinal band, and the inferior extension, which attaches the body of the atlas axis, is the inferior longitudinal band. After removing the tectorial membrane, we can see these ligaments, and at the side we can see the alar ligament in the upper part, and in the lower part we can see the transverse ligaments of the atlas and the deeper accessory part of the tectorial membrane, which are atlantoaxial ligaments. And after removal of these cruciate ligament, we can see the alar ligament and anterior atlanto-occipital ligament. Next slide. Now biomechanics. Now we can see that the flexion and extension movement occurs at occipito-atlanto-axial complex, which is the most mobile unit. Axis being interposed between the skull and cervical spine like a washer. Flexion extension movement occurs occipito-atlantal and the atlanto-axial joint, and it accounts for about 25% of the flexion extension movement in the neck. In children, anterior-posterior translation occurs between anterior arch of the atlas and dens. So it is called as predental space, can go up to 5 millimeter, up to the age of 8 years. Some textbooks recommend that it is up to the 9 years, but 8 to 9 years is common. And predental space should be less than 3 millimeters. Next slide. Once there is disruption of the cruciate ligament, the load is then placed over the alar and the apical ligament, which are the accessory ligaments. Then they can easily become incompetent. That will lead to the dislocation or incompetence of the cervicovertebral junction. Now, once there is damage of the cruciate ligament, then the 5 millimeter excursion of the dens in relation to atlas becomes very easy. In collagen disease such as Down syndrome and Markov syndrome and other congenital development diseases, which I will discuss later on, this space significantly increases even though there is not actual dislocation. Next slide. Rotation of the craniovertebral junction. Rotation of the neck up to 90 degree, excluding the occipital-atlantal ligament articulation. The largest degree of rotation occurs at the atlantoaxial joint, and in children beyond 25 to 30 degree. It brings the middle and the lower cervical segment into action, which prevents the increased rotation at the atlantoaxial joint. Stretching and kinking of the contralateral vertebral artery comes into play beyond 35 degree. And beyond 40 degree, interlocking of the facets occurs between atlas and axis. When acute rotation of atlantoaxial joint occurs, it is about beyond 45 degree, the vertebral artery goes into angulation and occlusion, and it can lead to vertebral artery occlusion and even disruption, which may lead to vertebral basilar incompetency. Next slide. So what is the applied aspect of this biomechanics? Children with assimilated atlas participating in the contact sports like football, wrestling, and those who undergo excessive rotation of head during procedures like general anesthesia or forceful head manipulation, they should be handled with caution. Absent of ancovertebral joint, which is the extension of the lower border of the body of the vertebral body, which articulates with the upper border of the lower vertebra, is absent in pediatrics, and horizontal orientation of the facets in children makes it increasingly mobile. The cervical paraspinal musculature principally have clamping motion, which holds the craniovertebral articulation in place and maintains the neck in normal position. Next slide. Now, word about maturation of the pediatric spine. Immature pediatric spine differs biomechanically and physiologically from its adult counterpart. The characteristic of immature pediatric spine make it resilient over injury. It also confers specific weakness that accounts for the unique injury pattern. Radiographic bony maturation occurs around 9 years, as I told. Non-osseous components of the vertebral column do not completely resemble those of the adult until adolescence. Children between 9 and 12 to 14 years represent an intermediate group, and the spine of adolescent 12 to 16 years represent almost adult-like vertebral column. Next slide. An infantile spinal column consists of series of elastic cartilages that are surrounded by connective tissue, which are less elastic. Spinal cord itself has intrinsic elasticity, although not as much as the vertebral column. Biomechanical studies in neonatal cadavers have shown that elastic vertebral column can be stretched up to 2 inches without any structural damage, while relatively inner elastic meninges and spinal cord get torn even if you stretch up to 1/4 of an inch. So it shows that vertebra's bony structures are more elastic and stretchable as compared to the neurovascular structures. Next slide. Increased mobility in pediatric patients, mainly due to laxity of the ligaments and fulcrum of the head and neck, is age dependent. At C2, C3 in infants and children act as the fulcrum, C3 and C4 at age of 5 to 6, and in adolescents that shifts to C5 and C6 vertebra. This transition is accounted for by the diminution of cranial body disproportionate with age and age-related maturation and development of vertebral column and ligamentous structures. Next slide. Neonates and infants are highly vulnerable to high cervical vertebral column and spinal cord injuries with after extension and flexion trauma. In infants, lacking a well-developed neck and paraspinal musculature, disproportionately large head, and to resist changes in inertia during fall and deceleration action contributes to increased vulnerability. Next slide. Unique subgroup of congenital anatomic genetic abnormalities predisposed to spinal injuries such as syndromic kids of Down syndrome, Marker syndrome, and children who are having rheumatoid arthritis, hindbrain herniation, carry malformation, Klippel-Feil syndrome, and surgery at the CVJ. Must be remembered that instrumentation is not only a temporary fixation until we got the bony fusion occurs. So this should be kept in mind. Please. Next slide. Now looking over the degree of freedom and movement at the craniovertebral junction structures. It has got 6 degrees of freedom, as we can see in the pictorial diagram showing X, Y, Z axis and the movement along the 6 degree of freedom. At atlanto-occipital joint, there is pitch, rolling, and contrary sliding movement, and atlanto-axial joint, entire 6 degree of freedom is there. Next slide. This atlanto-axial joint, along with the occipit, it's like an orchestration in which Shirobheda, where there is 9 postures of the head in Bharatanatyam, and the right part of the screen shows the joints of atlas and axis, where upon axial loading on vertical compression, the axis goes in the posterior and downward direction, leading to rotation. Next slide. These are the points for the craniometric measurements which we use to measure in order to identify the atlantoaxial dislocation and basilar invagination. Next slide. This is a schematic diagram drawn by my colleague, Dr. Priyadarshi Dikshit. He is a very nice artist and a neurosurgeon. So he is trying to show the basic lines like Basion to Opisthian, Macrie's line, Chamberlain's line, McGregor's line, and Wackenham's clival canal line. And he's trying to show that there is a high index of Claus in the form of vertical line, which is drawn, and platybasia. Next slide. This is the uppermost is the normal radiograph, and the lower images of the CT scan, cital cut, trying to show basilar invagination, atlantoaxial dislocation, and assimilation of the atlas with the occipit, and all these complex anomalies. Next slide. This in order to show the 6 degree of freedom and 3-dimensional Cartesian system. From our center, we have published an article in which we have tried to show that this is not only a 2-dimensional measurement of anterior-posterior dislocation in the form of atlantodental interval. In addition to that, there are other complex movement in the form of central dislocation, translational dislocation plus central dislocation, translational dislocation plus rotational dislocation, and coronal tilt, which makes the entity complex. And further, central dislocation along with coronal tilt and rotational dislocation, and combined type of dislocation where all the entities are present, which occurs in all the 3 axes and all the 3 planes. So according to this, we have got 6 type of atlantoaxial dislocation based on the XYZ Cartesian axes. Next slide. These are the radiology of patients who have been diagnosed using this 3-dimensional Cartesian system. Next slide. Role of effective canal diameter in assessing the preoperative and postoperative status of the patient. In order to find out the pathological anatomy, we have attempted to measure the effective canal diameter and analyze the outcome of the patient, which shows that there is significant correlation if the effective canal diameter is between 5 to 10 millimeter. Next slide. These are the radiology showing the compromised effective canal diameter. Next slide. Measurement of this effective canal diameter along with angle. Next slide. Next. Next slide. Yeah, measuring the effective canal diameter with the help of scale from the posterior surface of the dens to the anterior margin of the atlas or the opisthion. Next slide. Discussion of craniovertebral junction is incomplete without talking about syndromic craniovertebral junction. At our center, we have managed several patients of syndromic craniovertebral junction anomalies. As we know that more than 84 syndromic pathologies are associated with craniovertebral junction, with increased laxity over the ligaments and assimilation of the lateral mass of the atlas, and assimilation of the posterior arch of the atlas, improper fusion and assimilation of the craniovertebral junction vertebral, as well as vertebral vascular anomalies. So this was a publication from our center. Next slide. Along with neural anomalies and vertebral anomalies, vascular anomalies are also very common over the craniovertebral junction, and we have noticed that there is variation in the vertebral artery course, which makes the surgery challenging. But with proper technique, and mobilization of the vertebral artery, these patients can be handled and managed properly. Next slide. This is a radiology showing the anomalous course of the vertebral artery crossing over the atlantoaxial joint, and one side is dominant and one side is significantly hypoplastic. Next slide. Thank you for your kind attention.
Thank you, Ved. That was an extensive discussion. Arun, you want to cover the rest? Yeah. So, so you look at the applied aspects and the applications into daily clinical scenarios. Go ahead, Arun.
So my screen is visible to you all?
Yeah, go ahead.
Yeah, thank you, Ved, for laying down the foundation with excellent description of applied anatomy, embryology, and biomechanics in a very nice way. Now I'll try to build upon the simplified surgical strategy and algorithm for you all. So my dear friend, I'm Dr. Arun Srivastava, Professor Neurosurgery. And I just wanted to mention that we are working at a center which is supposed to be Mecca of CV junction anomalies. Let me start with some interesting fact, and I want you, all my young colleagues, to repeat with me. The first and very important thing is you should be knowing there is nothing like complex craniovertebral junction anomalies. Second very important thing you should be repeating with me, there is nothing like universal procedure. You have to tailor your approach. Third thing I want to say with me, there is nothing like only surgeon or I'm the only surgeon who will be able to do this case or will be addressing this case or my technique. And this is going to be the best technique. So in conclusion, there is nothing like you cannot do it. If you understand the biomechanics applied aspect, you'll be able to address these CVJ anomalies in a very, very nice way. So Anita ma'am must second me. There was a time maybe 15 years back when the understanding of this CV junction anomalies was very, very simple. There was something like bony anomalies, soft tissue anomalies, then in bony anomalies, some assimilation, some fusion, and atlantoaxial dislocation. And then there was very simple algorithm. Reducible atlantoaxial dislocation, go posteriorly, do instrumentation in reduced position, and initiate bony fusion or go for a robust bony fusion. Irreducible AD, go anteriorly, perform transoral decompression, go posteriorly, and do the instrumentation and bony fusion. Life was simple. But I think the outcome was not as good because we later understood the biomechanics better than what we were knowing at that very time, and rather applied aspect. And we started doing a lot of maneuver with the C1, C2 joint. So let me start with the this reducible AD subset in present scenario. Nothing much has changed regarding this reducible AD. So we all know, as Dr. Veda already explained, in the the posterior translational movement, there is a increase in ADI, atlantodental interval. In pediatric age group up to 8 year, it is around 5 millimeter, and beyond 8 year, up to the pediatric population, it is around 4 mm in literature. So if that interval in flexion is more than 4 millimeter or up to 5 millimeter, it is considered to be increased ADI like this. And then it is reducing on simple extension. And this qualifies in the subset of reducible AD. Then I just wanted to observe you people to observe these very important fact, like see the articular masses, they are very symmetrical. The joints are also the coronal tilt and sagittal inclination are within the normal range. So maybe because of the os odontodium or because of the ligamental laxicity, this was happening. So this qualifies into the reducible AD, and the treatment is very, very simple with the goal. We want to alleviate compression from the neuraxis in mobile AED or in reducible AED, this is achieved with a very simple maneuver, that is realignment. Once you realign the spine in extensor, there is no compression on the neuroaxis. Sometime you have to add bony decompression, sometime. So most of the time it's realignment which addresses the compression over the neuroaxis. And definitely you should be focusing on achieving good bony fusion. So this is what is the goal to be achieved in all kind of AD, but for reducible AD, it is very, very obvious. So what has changed over the year? Various type of instrumentation methods. So it is all on you. If you are comfortable with C1, C2, Goel-Harms technique, that is sufficient enough to do the instrumentation in reducible position and put a lot of bone. Or you can go for the Goel's plate method. You can even put cages and transarticular screw and wiring as well. So these are the surgical procedure which has increased in our basket, in our domain over the year, but the principle remains same. Reduced CV junction in a reducible AD, do the instrumentation in reduced position and induce bony fusion. But what has been added over the few years is some people came with the anterior approach. I'll be taking the author's name. If you want, you can read further regarding all these things. You can achieve the same thing through the anterior approach. And you must be knowing about Dr. Y.R. Yadav's approach of transcervical endoscopic method to address this instrumentation in reduced position through anterior approach. And Dr. Patekar, who is opting for the microscopic route, this transcervical microscopic route to achieve the same. I'll tell you in 1 minute. This is something like they, with anterior exposure, they are seeing the anatomy like this. Now they can put some plate here or some Y type of plate and screw in this CV junction, and they can fuse this CV junction in a reduced position, and even they can address joint from the anterior approach. So it's on you, whichever suits you, you can perform this surgery in a reducible AD. Actually, everything, whatever complexity has happened or been talked about in recent years is for the irreducible AD. And it has all happened after this revolutionary concept of joint manipulation, remodeling and realignment of CV junction bony anomalies. So there is no doubt that if you could realign the joint even in irreducible AD, that going to be most accepted, biomechanically most accepted surgical strategy. So I'll take you through this video. What Dr. Ved just explained all of you. This is the translational movement, anterior and posterior. This is flexion extension. This is lateral tilt, and this is rotation. What I want to highlight here is no motion is going to occur in isolation. All the motions are happening in coupled way. So it is like whenever there is when the dens is going anteriorly, means if you are reducing the AD, you are not only achieving the reduction in translational distance, you are also achieving extension. So you are also achieving the extension. And then you are also achieving decrease in the basilar invagination. So I'll show you that as well in some radiology. So lateral tilt is not always happening in isolation. It is actually lateral tilt is coupled with rotation. So all these movements, they are actually happening in coupled as a coupled movement. So you should be knowing the very important fact, the biomechanics of CV junction is actually not an isolated movement. They occurs in a coupled way. So this is known as coupling of the movement. So what we have done over the year, that the SGPGI is has come up with this concept of dividing this irreducible atlantoaxial dislocation in two types, type 1 and type 2. So what we are going to achieve is this type. So type 1 are where the bone hypoplasias are not there. Hypoplasia, I'm talking about the articular masses. Or if at all it's there, it is a very mild degree. The C1, C2 joint, when you compare on either side, is more or less symmetrical. And if you see their coronal tilt and their sagittal orientation, they are near normal. So C1, C2, I used to see in a horizontal, in lateral view. If it's more or less horizontal, so I understand this joint can be easily negotiated. And one very important thing you have to see is the vertebral artery anomaly, because you are going to enter into the joint, you are going to manipulate the joint. So if a dominant vertebral artery is crossing over the joint, then it is going to be a difficult scenario, difficult surgery. So if these factors are there, so you can very well attempt posterior only approach with joint manipulation, and you can achieve reduction. So I have talked about this type 1. This is actually qualifying into type 1. This is increase ADI in even extension, increase ADI. Articular mass is more or less qualifying this type 1. So see what you can achieve. This is occipit. This is occipitalized C1. This is C2 spinous process. It is one of my very old video of 2008 or 9, I believe. So that time I used to cut the C2 ganglion. So here we have opened the left C1 C2 joint. See, and then we are just cutting all the ligament and cartilage. Now it is the right-sided joint. Once both the joints are opened or manipulated, you will see how beautiful it's reducing. See, the C2 I'm pushing is going and exactly anteriorly. And what is happening? As I already explained you during the coupling movement, it is not only reducing, it is also the BI component is also coming down. So this is the left-sided C1 lateral mass. We are using knock and drill technique, which has been published in literature. And through that, actually, we are doing these surgeries without utilizing any fluoroscopy. And the accuracy rate we are about to publish is also very good, up to 90%. This is, we are going to drill the C2 parts. And this is the C2 parts scoring. So again, utilizing the knock and drill technique, and this is how the type 1 irreducible AD converted into reducible AD, and the surgery is done exactly the way a reducible AD cases are done. So this is with a robust bone graft. So that is how it is done. See what has happened. If you follow the Wickenham-Clivus canal line, there was a mild BI, there was increased AD, increased ADI. So what happened? There no BI, ADI is normal. In translational vector, it has reduced completely. So if you understand the biomechanics and if you follow this surgical algorithm, you can up to 60% of irreducible subset can be addressed through this very strategy, and you can reduce it by joint manipulation and joint remodeling. So we have applied this concept over several cases in our at our center, and we were able to achieve the nice reduction. You can see here, nice reduction with the joint manipulation in cases of type 1 irreducible AD. This was a case of rheumatoid arthritis with a rheumatoid ball in the lung. Here, the C1 lateral mass was very, very fragile. So we have achieved the same with the occipitocervical fusion. Some people are saying occipitocervical is dying. No, gentlemen, I think occipitocervical fusion is again a very good procedure to make some patient less morbid and happy with your surgery. And the same very thing can be achieved by tailoring the surgical approach. As I was mentioning, tailoring means here we have put lateral mass on the left side of C1, lateral mass on the right side of C1. C2 parts on the left side was good, but C2 parts on the right side was thin, and there was a high riding vertebral artery. So what we have done, C1 lateral mass, C2 parts, C1 lateral mass, and here C2, C3 is fused. So we have got a big mass, bony articular mass here, and we have put screw here. So this is all you have to tailor. I mean, you don't want to put the vertebral artery in danger, and you can safely come down and can utilize this articular mass. So we have utilized this for many cases of type 1 irreducible AD. What's about irreducible AD type 2? So what I used to club those cases where articular mass hypoplasia is of severe degree. There is platybasia, very bad retroverted odontoid with high degree basilar invagination, fairly asymmetrical C1, C2 joint, and near vertical sagittal orientation of C1, C2 joint. I'll show you just after a few slides. And because you are totally relying and dependent on the C1, C2 joint manipulation, so non-negotiable vertebral artery anomaly is going to limit your surgical procedure. So what best you can do? The safest way in your hand. So I'm just talking about these kind of cases. See, if you talk in terms of listhesis, this is you can call it as a spondyloptosis. This is I'm talking about this the horizontal C1 C2 inclination in lateral sagittal plane has almost become the vertical. Here also the vertical. So these are the joint. I think it's very difficult to negotiate with the joint manipulation, because you have to look the joint in this vector. This is not possible. This vector, it is very difficult. This is the vector. You have to see the joint like this. Few people says I can drill the joint like this, and then I can, you know, realign this. Yes, possible, but in a very, very experienced hand. And again, what you are putting on stake, a very critical neuroaxis area of craniovertebral junction, which is already very, very compromised. So a simple answer, transoral decompression followed by posterior fusion. Maybe your radiology is not looking good, but your patient is smiling and happy in front of you. So this kid I'm following from last 10, 11 years is doing very good. See the amount of decompression, and then in situ fusion from behind. So this is also a treatment option available in your basket, and it is very effective, believe me. Just like OPLL, if you're not able to address it from anterior route, you are doing the laminectomy and instrumentation from behind area, and your patients are doing good. The same thing can be applied here. Now, Anita ma'am and Suhas sir, you'll be surprised to see this case. This child was brought by he was not, he was orphan, he was brought by his fellow villagers, and he was severely quadriparetic. His odontoid tip was kissing the posterior arch of the C1C. And his spinal cord was bean-shaped like this. So very simple approach. Transoral decompression and posterior fusion with wire only. And this kid is under our follow-up doing good. A simple surgery, which people are saying it's a dying art or whatever, but I'm saying with some dying art, if you can save a dying patient, it is worth taking a chance. So I will be giving a few minutes on this oblique approach. See, this case of irreducible AD was qualifying into type 1 irreducible AD, good articular masses and symmetrical, though the sagittal orientation was bad, but with increasing experience, we were sure of reducing it intraoperatively. This was the case after many, after a long time, we have used fluoro because it was not reducing during the surgery. So when we have re-looked over the radiology, we found this was probably the cause for not getting this C1, C2 reduced during the surgery. So what we have done, we have came from the right side of C1, C2 joint obliquely, and we have drilled everything, all fused bone through this trajectory, and we were able to achieve the reduction. So what we have done, we started doing over the year, we started selecting few patients amongst type 2 of irreducible AD, and we are utilizing this bilateral oblique approach, and we are able to achieve realignment in those subsets. So that is, I think, with the learning curve, it's almost 15 years down the line, I'm doing exclusively CV junction. So this is possible. But if you see the simple treatment algorithm, the reducible AD, still you are having a very simple option. There is no doubt, no confusion about it. Only the irreducible component, if you understand these are the subset, can be very well make irreducible to reducible with simple joint drilling manipulation. You attempt those subset with the posterior only approach. Otherwise, you have very elegant option of anterior decompression followed by the posterior fusion. So with this, I would like to conclude my presentation that whatever Dr. Ved has tried to teach us is very, very important, because understanding these biomechanics are going to help us in managing these cases. And don't be rigid with the procedure per se, or don't get, something like, this is the only procedure, this procedure address every kind of CV junction. It's not like that. You have to tailor the approach. Even the instrumentation on right side may vary from the left side. So that is what CV junction is all about. And I could conclude with my presentation. Thank you so much for your patient listening.
Thank you, Arun. That was a very interesting way to put all the details of CV junction. It's very, very complex. So I think if a resident cannot learn everything from one presentation or this small 1 hour of effort from our side, they have to take it from here onwards to read and keep working on those aspects of the basic biomechanics and the knowledge. Thanks a lot. Thank you. I think Madam Dr. Anita. Dr. Anita is a professor and HOD at GB Pant Institute. She's with us. Madam, you want to take over? Dr. Anita?
Yeah.
Hello.
Yeah.
Madam. Madam, yeah, you can take over. There are some
Yeah.
questions in the chat box, and your resident presentation, however way you want to handle it, you can handle it. No problems. Go ahead, please.
Oh, fine. Yeah, so thank you for inviting me for this one of my favorite topic of neurosurgery, that CV junction. Am I audible? Is it okay?
Bit of an audio disturbance. If you can improve, I don't know.
Yeah.
Some audio disturbance.
It is fine, right? It is fine now, right?
Yeah, it's getting better. Please go ahead.
Yeah.
Please go ahead.
Good, great presentations by Dr. Ved and Arun. It was really wonderful with the basics and the very nice cases which are shown by Arun, the oblique technique and the case which was there, which he showed with the child, and the whole density, the whole canal is occupied by the bone actually. And you see, when you see that 2/3 or 1/3 of the cord actually occupies the canal. So even if it is good compression of the canal, if you see that there is very mild canal diameter is left, even in the patients, they can walk, right? And they can walk because of this, because that only 2/3 or 1/3 of the cord occupies the canal, and secondly because of the spasticity that helps them to stand and walk instead of flaccidity, which happens at the CV junction anomalies. So in children, one more thing is that besides trauma, the infection of the pharyngeal wall, which is quite common in the young age, they can get the infection, and they can, that can be retrogradely spread to the CV junction area, that is Grissel syndrome, and that is also one of the cause of CV junction anomalies in children. Then, of course, the cases were shown very good, and there were a few questions which I read in the box that, you see, the preoperative assessment is very essential. And of course, you don't require, in this era, you don't, even when I was doing and when I was resident, every patient was put on the tongue for 1 week or so, and that you wait for the reduction to happen, and then you take the surgery for the patient for the surgery. This is not required anymore, except in the conditions when the respiratory involvement is there, when there's respiratory difficulty, and you feel that patient you want reduction to happen, so you put those patients on pre-op tongue traction, otherwise it is no more required. Fluoroscopy definitely is required intraoperatively. And I would like to comment to three more things, which Ved also showed few X-rays. And if you see, besides the bony misalignment, you can see the lordotic curvature of the cervical spine also. That shows that the child has some muscular anomalies or the collagen anomaly. So that few of these cases had shown hyperlordosis along with the CV junction. So you should see the lordotic curvature of the cervical spine as well. Yes, shown very nicely the Bharatanatyam movement is the head movement of actually the flexion extension is like the pigeon moves the head and neck. That is the flexion. That is the movement which happens at the CV junction. And of course, it is a 3D. It is a 3D anatomy which you should see at the joint also. So, and the main thing is that when you're seeing the articles, it's not the bony anomaly, it's not only the anatomy, vascular anatomy as well. So if you see the VA course, you should see not only the course of the VA along the facet joint, but you should see the course of the VA in the, if you the vertebral foramen in forward and which quadrant the VA is passing through. Because when you're putting the screw, sometimes if you see that it is touching the, breaching the medial wall of the foramen and going into the canal, going into the foramen, still patient do not show with any vertebral artery involvement post-operatively. They don't manifest with any deficiency of the VA involvement. So you should see that also in the cross-section of the VA foramen, the location of the vertebral artery in relation to all the 4 quadrants. Then, of course, you should see the other congenital, vascular, and anastomosis also. You may find proadrental arteries in these cases. So it is not only high riding artery or the artery in relation to the foramina. You may find proatlantal artery, you may find other anomalous courses of the artery, because it is in pediatric cases, besides trauma, you find congenital anomalies as well. So you should be careful about those. Sometimes the vertebral artery hypoplastic at one side and the good caliber on the other side, that becomes a surgeon's, that favors actually surgeon in terms that on the hypoplastic side, even if you want to put the screw, you can sacrifice the artery. So not only VA the course, you should see many things in the VA. Then, of course, in children especially, when you are seeing the graft, the bony graft, in children you don't get the good graft, bony graft only or into the facet. So that is another challenge in pediatric CVJ, which is where you can use, because you get big cartilage but less of the bone. So it's very difficult to put the onlay graft as well as the graft into the facet joint. So that can be replaced by BMP blocks, which can be a very good choice to fill up the joint as well as testing the onlay graft. Because as Arun and Ved both said, that it is the bone union which is most important. So alignment in bone union is most, and as Dr. Atul always speaks in his talks, that joint is the game. And that is true, joint is the game. If you're not treating the joint, even if you feel that you have achieved a good reduction, the subsidence can happen in future. So you should be careful about that. In one go, you find that you have achieved very good alignment, but after say a few months or few years, you may see that there is recurrence of the anomaly. So for that, joint, addressing the joint is the most important thing. Whether it is reducible, it is irreducible, it is congenital, it is bony. Addressing the joint is very, very important thing. So I think, and of course, transoral approach or high cervical approaches, as Arun said, they are equally, like, you cannot say that you want to do this and you will go and do the same in the surgery. You may find some new information during the surgery, which may be sudden shocks to you. That can happen. And so for especially transoral and high cervical, one should also learn these approaches, because as Arun shows that a case with where he did the odontodectomy first and then went posterior. That is one type of case. Sometimes you find that the bony, there are 2-3 bony ossicles fused with the clivus. You are not able to reduce it because they are relying there. What oblique technique here, that is a very good alternative. But of course, you need to be master. You need to learn this, master it, because there are chances of you need to retract the cord, the dura, and then you not cord, dura, and then you can do the oblique dissection of the odontoid. For that, you need to learn the high cervical approaches. It is something like your anterior corpectomy, but of course, there are some important structures which come in way, the submandibular gland. But the moment you retract the submandibular, it's a good roomy area where you can work nicely. Of course, there are limitations for that, and you need to learn. You need to know that what are the indications for anterior high cervical approach or transoral approaches, and where in all the cases it is not essential to put the occipital plate also. In my time, the occipital plating was like one of the component of CVJ fixation, because there was a concept of occipital settling. Just to prevent the occipital settling, occiput used to be taken into account in the fixation, whole fixation. But you may get it away by playing with the joint and then onlay graft. So these are the few things which I really wanted to add.
Yeah. And sometimes, the occipital cervical is useful when you have a very abnormal kind of C1, an absent C1 posterior arch. And I found it useful in children with ligamentous laxity, Morquis, etc. Even if you do C1, C2, the failure rate is very high. So
yes,
sometimes the occipital cervical fusion becomes a key rescue procedure in most of these children with ligamentous laxity, etc. So I think,
yeah. So you're absolutely right. With ligamentous laxity, it is very good procedure. But occipital C1 is never a contraindication for C1 lateral mass. Even if the lateral mass are not well formed, you can go from the superior aspect of the facet joint and can go into the lateral mass also. So posterior arch is not the contraindication, right? Of course, laxity requires occiput involvement also.
No, but at the same time, madam, we find it very challenging. The youngest, I mean, Vedan, Arun have not covered it. The youngest ones, infant coming with CV junction anomaly with deficits, you don't have much of choices, isn't it? And let's say infant, the youngest ones. So how do you now? One of the questions is instrumentation in the youngest. So how do you comment on it?
Yeah, so Suhas, I have done up to 3 years of age with a C1 lateral mass screw. Of course, below 3 years, I have not done any case. In 3 years, initially there was Medtronic, which was making the screw of 3.5 initially. But now if you see many Indian markets, they have come and they can customize the screw size also. But of course, they are more cartilaginous, the bone is not so strong. So you have to be careful. Your drill bit also cannot be 3 millimeters as standard you take. So you have to customize, reduce the size of the drill bit, measure C1 lateral mass, entry, the diameter, everything before going into it. And before that, like if the younger than the 3 years, you can always go for the conservative treatment or the wire or the silk also. I've seen seniors putting the silk also, tying them with a silk, tying them with the Athibond, and that works. It's not that doesn't work. Yeah. That works for these small children, and then you can take them in the later follow-up period. How do they go?
Exactly. Sublaminar wiring is a very useful rescue technique. And, if you have a very good graft, like a rib graft, and we use an external customized brace. So sublaminar wire, rib graft with an external brace, I found it very useful in the youngest ones.
Yes.
Yeah, no, I agree.
Vedan, Arun, you want to take some questions from the chat box?
Yeah, definitely.
Look at it from systemically from the higher up down, whatever is useful. One is a C2 root sacrifice. What is preferred, pre-ganglionic or post-ganglionic? You want to answer that?
Yeah, actually, the post-ganglionic, they further divide. So it is very difficult. Sometimes you get confused with the vascular structure as well. So it's safer to cut it pre-ganglionic. If at all you are going to sacrifice it, because it is only one root, and pre-ganglionic you cut it, and it is the portion which is lying over the joint. So unnecessarily going lateral and cutting something else during that process. So it's always prefer If at all you're cutting, cut it pre-ganglionic. And believe me, during surgery, you will not be able to see those kind of things. Because,
Identify.
yeah,
You can't identify.
yeah,
You will be cutting the ganglion only.
only ganglion.
Yeah.
So whatever is coming in you lying on the joint, and you really need to see the joint, and you are not able to negotiate it, then it's safer to cut it, but always do it with a sharp dissection. Don't use monopolar, don't use any other method. Just dissect all the muscles and other tissues, and then cut it sharply. Cut it sharply, because a lot of videos we have discussed about the sharp dissection, keeping the field without, I mean, almost bloodless. Definitely you will keep on doing those kind of procedure with this much of clarity. You will start understanding the CV junction better than others.
Okay.
Yeah, you can use intraoperative Doppler also. When you have the doubt, you can use intraoperative Doppler also to identify the artery, and you can use intraoperative angiography.
If
you have some doubt, because sometimes there you get transmitted pulsation through the root.
Yes, no doubt.
Okay, wonderful, thank you. So, and a question regarding traction: do you apply traction preoperatively for and for how many days? Do you want to comment on it again? Madam mentioned something. You want to comment to clarify it again?
No,
traction.
Actually, we are not putting traction pre-operatively, as ma'am Anita ma'am rightly mentioned about that very subset. Rather, we have started not using the traction even during surgery for a very big subset of patient. We are just putting the patient on the 3-pin, 4-pin, and we are we after manipulating the C2 anteriorly will be able to achieve the reduction. So in large subset, even we are not putting traction during the surgery. We are achieving the reduction with the 3-pin, because one very important factor, ma'am will agree with me, is the blindness in some cases. In our series, when I collected the data of 3 decades of pediatric patient management, I found 3 patients becoming blind during the surgery. One eye, 2 patient, and 1 patient both the eye. So this if you put the patient on traction and then you're manipulating, you don't know when actually the eyeball has got under pressure. So
for the horseshoe.
A lot of patients we are doing with the only 3 pins, so eyes and everything is free during the surgery.
Yeah, that's central.
Can I add?
Can I add? Go ahead, madam.
So
go ahead.
Even that is a big challenge, what Arun told. Of course, nowadays you get a good horseshoe with silicone padded, and you can adjust the distance nicely. You can see the whole face, whole eyes. It has come with the Mizuho table, the attachments, separate attachments with a good silicone jelly padded. They are very good. And when you have position, even after putting the traction, you have to see it, because after putting the traction, it moves forward. So you check again the eyeball position, and from underneath that horseshoe, the silicone padded, you have the mirror also. One thing, you can check through that mirror, or sometimes the anesthetist, they should just click the picture that eyeball is very safely away from the pressure areas. So that is good idea. Like, that is an alternative one can use instead of the traction, the tongue applying. And another thing is, when you're positioning, while positioning, your position should be that your table should be broke. First, it should be neutral. The neck should be in the neutral, but the head elevated, and the leg also elevated. So leg area is elevated. That is pulling the body. Your lower body is pulling the down, the spine down, and the upper is pulling, your traction is pulling the head up. So that will help in the opening of the joint. And if you put this patient in military tuck position, this will open up the joint. So it will be easier to work in the joint in this position.
Arun, I had this event long back, many years back, and I looked into the etiology for this. So it is said that it's not just direct compression. Sometimes it has a vascular component too. So it's much more complex. Although it's very rare, it's much more complex than direct compression. So sometimes we will not be able to prevent it, including hypotension, etc. During surgery can cause central artery occlusion. So
just wanted to add one more thing. It's been mentioned in literature. If the surgery goes beyond 6 hours, that is also a very important factor. So so you have to cut down your extra times with something like when you are doing something X-ray, a lot of things, many picture and all. So gradually I learned a lot of things which if you cut down, actually you are cutting down the surgical time. So you rightly said the pathogenesis is
Physiology is very
uh,
complex.
very complex. Yeah.
Yeah. So one of the questions along with the X-ray thing is fluoroscopy used for positioning, or at what stage do you add CM? I mean, what's your protocol?
Yeah, actually, we are coming up with a publication that from last, I think, more than 10 years, we are not using fluoroscope during the surgery. We are just using freehand technique. So believe me, with this, I can very well tell you that the fluoroscopy is actually not required once you really understand the biomechanics and you start understanding in the dynamics after the reduction and how it's going to reduce. Yeah, I'm not saying you should not be using, but I'm telling you the CV junction is actually something when you understand the biomechanics. That is why I requested Suhas sir to separate this topic from whole spine, because this is a very unique area. It's a very unique topic. So first of all, the for positioning you don't require fluoroscopy. I think Anita ma'am will second me for that. And during surgery, yes, if you are comfortable, you want to see the reduction, you want to see the things, but believe me, it is an anomalous case. Actually, you are not going to have a normal craniometric finding. So this is actually not going to help you, rather it's going to deceive you or confuse you. So, but you can, yeah, you can use, but during the surgery when you want to see the reduction or something like that. Otherwise, you don't require fluoroscopy for positioning.
One instance I had was, I had a CM before and I had a CM after surgery, and I realized that was again long back. The C2, C3 had come into the wire. The C1 was absolutely, and this was an infant, of course. C1 was absolutely cartilaginous and a threadbare thing. So we had missed the C1 completely. I mean, as a complication, infants are completely a different challenge when it comes to CV junction. Junction.
Yeah. You rightly mentioned. I have not covered those cases.
Because
infant portion I missed.
They are very difficult subset, and I had discussion with Dr. Chatterjee and all. So most of the cases, as you rightly mentioned, they required occipital-cervical fusion. Believe me, the C1.
Especially the syndromic ones.
Syndromic ones. Bifid from anterior, from posterior, they are two separate half ring.
Complete overview.
Some things with C1, C2, actually the lateral deviation and lateral instability is still happening. So it's very safe to include occiput in those.
Yeah, agree.
Can I add to that? Fluoroscopy, like not using fluoroscopy is not a very great idea, because if you are doing only occipital cervical fixation, then you don't require, right? But when you are even in lateral mass, you may not require the fluoroscopy. When you're doing sublaminar fixation, then also you do not require the fluoroscopy. But fluoroscopy is required to just check the pre-operative condition and match and just compare with the post-operative. And secondly, that when you're putting in the C2, one is normal C2, but if the C2 is not normal, recently we did a case where the C2 spinous process was not there. Normally, it is very rare to have not to have the C2 spinous process. Just if you want to into the superior articular process of the C2, then you require just to see the entry point, is the entry point correct? So it's not that it is not required always. You may use it, but don't use it as a primary guidance. Ultimately, your anatomical knowledge is more important.
Yes.
It is just add on to your anatomical knowledge.
I mean, from the resident's point of view, do you think in other adjuncts like navigation, robotics can have some place in CV junction surgery?
I think, sir.
Yes, Suhas, you are right.
Yeah, ma'am, please.
Yeah, Arun can continue.
Hey, ma'am, please.
Continue.
Basically, sir, the CV junction is a disease of poor socioeconomic status, and as well as it is a disease of developing country. If you are having these systems, these gadgets at your center, you can very well use it. But what we have concluded from our study that actually the accuracy regarding the malposition of the screw is actually not varying. What Anita ma'am rightly said, knowing the right anatomy and knowing your intraoperative finding is very, very important. And then we have compared our accuracy rate with freehand technique was 87%, 88%, and their accuracy with very small number of cases was around 90%. So yeah, if you are having these gadgets, definitely they are going to increase the accuracy. But I think master the biomechanics and anatomy, intra-op anatomy. Try to relate with the 3D CT anatomy of the CV junction, and then and one very interesting concept is having a bone model, having a printed
3D bone model.
Yeah, that is
Yeah,
that
a
is
print
going
of
to-
it.
yeah,
A 3D
that is
print.
going to- yeah, that is
3D
going to
printing.
change
Yeah.
this approach,
Yeah.
because you can hands-on pre-operatively, and you can simulate same thing intraoperatively. That's going to help.
Yeah.
But I think navigation OARM is actually overkill kind of thing.
Okay.
Can I add something, sir?
Yeah, go ahead.
As sir very well pointed out, that we should know the anatomy
Biomechanics.
very well. Understanding the distorted anatomy, like pathological anatomy, is the key. And at our center, we are using the knock and drill. Means we are not following the normal landmark. We are following the pathological landmark, and we are navigating the pathological portion of the bone, and we are doing the instrumentation and the surgical intervention. First thing, and second thing, like other than 3D printers, we can use SAW models also. SAW model 3D printers. That 3D printers will give the exact replica of the pathological anatomy of the patient. But it's little bit costly at present at our setup, but we are working for that. Hopefully we can do that. That's it.
I think, we're running out of time.
Can I add?
Yeah. Go ahead, madam. Go ahead, madam.
Actually,
Please.
navigation and robot, advantage of robot will be you are not using any X-rays, fluoroscopy. So that is added advantage if you have the robot. One thing. Second thing, the 3D model, as he said, that cost 10 rupees to make 3D model, right? So actually, you need to understand the 3D anatomy in the brain. Just see the axial, sagittal, coronal cuts and make the 3D anatomy in the brain, and then start working. So you need to work that much. You do so many dissections. Putting the screw the last and the very easy thing. But reaching to that area is the most important thing. It is something like you are dissecting and applying the clip. The clip applying is the last thing. If you've done everything good, you can apply, anybody can apply that. Similarly, if you've done the very good dissection, exposed to everything fine, and putting, so you need to do many dissections, at least 30, 40, 50 cases dissection. And then you can master yours.
No doubt.
Thank you, madam. Thank you, madam. Madam, we are running out of time. Shall we close the session?
Yeah.
Is that okay?
Yes.
Yeah, madam,
Yeah.
can you maybe you can give us the closing remarks on the CV junction part, the academic part of it?
Yeah.
Thank you, Swat. I think it was a very good discussion. I think Ved covered the basics very well, and Arun really covered the biomechanics very well and showed the scans, and we had a very good discussion. And with the help of Dr. Anita, I think if there are no more questions, we can definitely close the session. I think we are already beyond time. I think, but it's a good attendance. I think
Wonderful.
We really congratulate our speakers. They are putting up really hard work. And really, I think it's really helping the residents also.
Agreed. And thank you, Dr. Anita, for joining us. And I think you made the session extremely resourceful, along with my own colleagues from industry. And thanks a lot, Dr. Anita.
Thank you. Thank you.
Thanks a lot, Arun. Thanks a lot.
Thank you, ma'am. Thank you, sir.
And to all the residents who are participating just now, this is an industry endeavor, and it's there every month last Sunday. The next one is going to be on September 16th, and the topic is biomechanics and management principles of the rest of the spine. We had CV junction in a bit of our own effort, but the rest of the spine will be covered in the next class. And by the way, just to mention, somebody had asked about the YouTube channel. We do have a YouTube channel, and these classes will be uploaded into that at appropriate time regularly. And you can of course send us your mail regarding your choice of topics if you have anything which is but the topics which we will discuss will be part of pediatric neurosurgical topics only. We will not cover topics which are overlapping with other different specialties. Thanks a lot for joining, and thank you. I thank my speakers and Dr. Anita once again. Thank you, and good night to everybody.
Thank you.
Good night, everybody.
Thank you, ma'am.
Good night.
Good night.
Bye, everyone. Thank you.
Good night, everyone.
Bye, ma'am.
Thank you, madam.
Good night to everyone. Thank you, everyone.
Thank you,
Thank you.
Shweta.
Thank you.
Thank you, ma'am.